Fabry disease. This is Dr. Sana Al-Khatib, and she's a tenured professor of medicine at Duke University Medical Center. She got her MD degree from the American University of Beirut and trained in internal medicine, cardiology, cardiac electrophysiology at DUMC, where she got her master's in health science degree. Dr. Al-Khatib has really gone in deep with Fabry disease in the heart, and I think she's got some really important updates and lessons for us. So I'm very excited to see and watch this lecture.
Great, thank you very much, and thank you for having me. I actually participated in this meeting in 2018, and it was a pleasure for me to do that. So thank you so much for having me back. And before I start my presentation, I wanted to share some heartfelt words of gratitude for Jerry Walter. Not only has he been an amazing person to know, but he actually taught me a lot about Fabry disease, and so it's been a pleasure to know him. I've actually ended quite a few of my presentations with the following quotation, but I'd like to mention it here because it reminds me of how Jerry has lived his life. You know, we make a living by what we get, but we make a life by what we give. Jerry, thank you so much for everything that you've done for this community and for all of us.
And Dr. Al-Khatib, thank you so much for everything. And I'm sitting here today, well, actually sitting and standing, walking around because of Dr. Al-Khatib. And I've just extended my time on the planet with my new heart transplant. So everything is coming together wonderfully, and I appreciate everything that Duke and Dr. Al-Khatib have done. And we have a great relationship, and it's wonderful for Angela and I to share that with you. Thank you.
Thank you very much, Jerry. You look great. So just starting with some disclosures here before I delve into my presentation. And I don't think I need to tell anyone here what Fabry disease is, but in case there are people on the call who would like to know, this is an X-linked inborn error of glycosphingolipid catabolism. So there is a deficiency in an enzyme activity, and because this enzyme is not able to metabolize this glycosphingolipid, it ends up accumulating in vascular endothelial lysosomes of the kidneys, the heart, the skin, the brain, leading to the main manifestations of this disease, as many of you know. As you heard from an expert in this area, enzyme replacement therapy certainly works. It clears these deposits from the kidneys, from the heart, from the skin, reversing many of the manifestations of this disease, which is great. I'll be touching a little bit on that when it comes to the heart. So as you heard, I am a cardiologist. Actually, my main subspecialty in cardiology is electrophysiology. So I focus on arrhythmias. And so most of my talk today will be on arrhythmias, but I'll touch briefly on other aspects of the cardiac effects of Fabry disease. So as many of you know, certainly Fabry disease, because of these abnormal deposits in the heart, can lead to significant thickening of the heart muscle. And this is important, and we'll talk about how this can play a role in causing different arrhythmias. But it is also important because when the heart muscle gets thick, it can get stiff and it doesn't relax and fill up with enough blood to supply the whole body with the blood that it needs. And so people can actually have what we call heart failure with a preserved ejection fraction. We'll get to that briefly when we talk about heart failure. But something to keep in mind, this thickening of the heart muscle has a lot of implications. Scarring is important. I'll be talking about that as well, because this is the common pathway, so to speak, for many of the arrhythmias that we see in the setting of Fabry disease. Of course, there is some leakage of the aortic and mitral valves that can happen, arrhythmias, as I said, and heart failure. So this is what we're talking about. You have these abnormal deposits in the left upper figure, certainly abnormal looking heart muscle there. And on the right side, the right top figure, that's where using an electron microscope, we can see these abnormal deposits in the heart. So it's definitely been very clearly defined. And then very close to what I do is, cardiac MRIs of the heart to risk stratify patients with Fabry disease. And what I mean by risk stratification, and we'll get to that, is what is their likelihood of having life-threatening arrhythmias coming from the ventricles. These are the bottom chambers of the heart. And that is usually mediated by scar tissue that you can very nicely see here on this cardiac MRI where the arrow is. This is scar tissue involving the heart muscle in a patient with Fabry disease. Again, we will definitely get to that. And many people have thought about what causes scar tissue in patients with Fabry disease. But before I answer this question, let me actually take a step back and answer the question of what causes scar tissue to form in the hearts in general. And I can tell you that the most common cause of scar formation in the heart is when people have blockages in the arteries to the heart muscle, a condition that we refer to as coronary artery disease. And those are people who form plaques, cholesterol plaques in the arteries to the heart muscle. And when these plaques rupture, the normal reaction of the heart to that is to form a clot to attend to the injury, very much similar to how we form a clot when we injure our leg or our arm or our hand. And so that can actually shut off blood supply to the heart muscle, and then the heart muscle dies and it gets replaced with scar tissue. So that is the most common mechanism through which scar tissue forms in people's hearts in general. Fabry disease, as you very well know, is a rare disease. So what causes scar to form in the heart? And that's basically because of these abnormal deposits. Initially, the thinking was, because of this endothelial, meaning in the blood vessels, accumulation of the glycosphingolipids, that may decrease blood flow and as such oxygen supply to the heart muscle. And people speculated that maybe that's why scars form. But then people realized that that's probably not playing a major effect. And most likely what's causing scars to form is this injury, because you have these abnormal deposits in the heart causing inflammation, and that the heart kind of repairs itself, so to speak, by forming scar tissue. And I will mention to you briefly here why I am focusing on the formation of scar tissue. So talking about arrhythmias, and I'll get to the discussion about scar tissue when I talk about ventricular arrhythmias, that's second on this list. But I'm going to start with atrial fibrillation, then move to ventricular arrhythmias. These are the fast heart rhythms that we see in patients with Fabry disease. But I will also then touch on slow heart rhythms, slow heart rates, high-grade AV block. I will get to those as well. So let me start with atrial fibrillation. It is indeed the most common abnormal rhythm that we see in clinical practice. And the way I describe this to my patients is, instead of those top chambers in normal rhythm, like you see in the left top heart here, instead of those two top chambers squeezing and emptying blood at 60 or 70 or 80 beats per minute, which is the normal heart rate, these top chambers go into this abnormal, erratic, irregular heartbeat. So now all of a sudden they're going at 400 beats per minute, and that causes them to stop being able to squeeze, and they can't empty blood like they should. And so blood ends up pooling in the top chambers. And when blood pools, it forms clots. And these clots may go to the brain and cause a stroke, which is what I showed you here in this person in the figure this is the most feared complication of atrial fibrillation. I'm sorry? Somebody? Okay, I can continue. And so that is the most dreaded complication of atrial fibrillation, is these clots forming and then going to the brain and causing a stroke. A big deal. Now, of course, there are other complications from atrial fibrillation, like heart failure, for example. If the patient goes into atrial fibrillation and the heart rate stays fast, even at 110, 120 beats per minute for an extended period of time, that could indeed weaken the heart muscle. And that's true of all patients, not just patients with Fabry disease. The other thing to bring to your attention is because many patients with Fabry disease have thickening of the heart muscle that usually involves the left ventricle, which is the left bottom chamber. And that's one reason why these people go into atrial fibrillation. But the combination of the top chambers not being able to squeeze enough blood into the bottom chambers, and this left bottom chamber being too stiff to accommodate enough blood, that reduces the cardiac output in these patients, and that pushes them into heart failure, even if the squeeze of the heart itself is pretty good. So very important to keep in mind. And some people may say, well, how do I know that I'm having atrial fibrillation? And it is important to note that not all patients with atrial fibrillation have symptoms. We have this spectrum of symptoms where on one hand of the spectrum, you have patients who are completely asymptomatic from atrial fibrillation. And on the other spectrum, you have people who are severely symptomatic because they are either about to pass out or passing out or cannot function because of how short of breath they are, how fatigued they are. And of course, in the middle, you have a lot of different presentations, so, with mild symptoms, moderate symptoms, so on and so forth. So let me now move on to talk about ventricular arrhythmias, which is a topic that I actually have focused a lot of my efforts in my career on, because I mostly work on the prevention of these ventricular arrhythmias and the prevention of sudden cardiac death. So let me go back to this whole notion of scar formation that I shared with you earlier. We talked about how because of the abnormal deposits in the heart, that the heart kind of reacts to that through some sort of repair, and that's basically in the form of scar formation. The concern about the scar is it actually is the place that life-threatening abnormal ventricular arrhythmias can start. So these rhythms go in a circular motion, so to speak, around scar tissue. And if they're slower, they're generally well tolerated, 120, 130, 140. But a lot of these ventricular arrhythmias are very fast. They're starting in the bottom chamber, and that bottom chamber is going at 200 or 250 beats per minute. That really reduces the ability of the heart to pump enough blood. The cardiac output decreases. And as such, a lot of those people may end up passing out. Of course, if the heart rate is faster, patients may have a cardiac arrest. And so that's when you get into the range of more than 300 beats per minute of this abnormal rhythm coming from the bottom chamber. And it has the ability to cause what we call a cardiac arrest. And so that is really important to know about. Again, talking about scar formation in this particular heart, this was in the setting of coronary artery disease, as I mentioned to you, where people have a cholesterol buildup in an artery to the heart muscle. Again, that plaque gets disrupted, the body forms a clot. That clot stops blood flow to the heart muscle, and then people lose heart muscle and it's replaced by scar tissue. And that is really the substrate, so to speak, of ventricular tachycardia, ventricular arrhythmias. If fast, they have the ability to stop the heart. And I'd like really to take a minute and explain the difference between a heart attack and a true heart attack and an abnormal rhythm that causes cardiac arrest. Because many people, especially people not in medicine, kind of use the two interchangeably, but they're not the same. If you actually look at the figure to your right, that's what I've been talking about, of cholesterol buildup. That plaque gets disrupted. The body forms a clot. Once you have a clot there in the artery to the heart muscle, it shuts off blood supply to that area in the heart muscle. And without blood, without oxygen, the heart muscle dies in a few minutes. And then it gets replaced with scar tissue. That's what the heart attack is. Here, to your right, you'll see that the patient was in a regular rhythm. And then he goes into this very fast heartbeat coming from the bottom chamber. And then that really fast heartbeat degenerates into this chaotic, very irregular, erratic rhythm that basically is cardiac arrest. That's when this person's heart stopped. And that is the mechanism. Now, this rhythm that I'm talking about can happen without a cholesterol plaque, without a clot forming, but it could also happen in the setting of a clot forming, like in the setting of a heart attack. So what I'm trying to say is that a heart attack with a blood shutting down or shutting off to the heart muscle can indeed lead to these life-threatening arrhythmias. But these life-threatening arrhythmias that have the ability to stop the heart can actually happen without a clot, without any of that mechanism taking place. So what is sudden cardiac death? It is unexpected death from a cardiac cause within a short time period. We usually say an hour, 60 minutes. In a person without any preceding fatal condition, what we mean by that is that this is not a patient who is, being hospitalized because of a bad heart failure, or no, this is somebody who is, out and about. He might be or she might be sitting down talking to people, and then they go into cardiac arrest without any warning. And that's why we call it sudden cardiac death. So it is really important to identify individuals at risk for this tragic outcome. And if you look at Fabry disease, a couple of studies have actually investigated risk factors for sudden cardiac death in patients with this condition. Older age, male gender, thickening of the heart muscle, as we talked about, presence of scar tissue. And really, how you would detect that is by cardiac MRI, mostly. That is the best test available today to determine if someone has a scar or not, and how much scar tissue a person has. What is the distribution of scar tissue? Because all of that certainly can inform this risk stratification exercise that we go through as physicians. And then non-sustained ventricular tachycardia. So this is the abnormal rhythm that I described to you earlier, but these are really brief runs, meaning they're lasting for 3 beats, 5 beats, maybe 10 beats. The definition is less than 30 seconds. And many people say, well, if you determine that a patient is at an increased risk for sudden cardiac death, can you do something about it? And that's where the implantable cardioverter defibrillator comes into the picture. It is indeed very effective at preventing sudden cardiac death. And the traditional form is where we insert a lead or more than one lead into the heart and hook them up to a device and place the device in the pocket under the skin. And basically it sits there, it monitors the heart. If it sees that the heart is about to stop, it shocks the heart and saves someone's life. So very important to keep in mind. And someone actually described the implantable cardioverter defibrillator as having an emergency room implanted in your chest. Because, you know, some of you may be familiar with the external defibrillator shown here. But the issue with the external defibrillator is that you are so dependent on being in a place where there is an external defibrillator, where there are people who know how to use it, who would be willing to come to the rescue, so on and so forth. And in fact, it has been shown that for out-of-hospital cardiac arrest, really the survival rate ranges between 5 to 10%. So that's why for us, until things improve drastically with this community response to out-of-hospital cardiac arrest, the implantable cardioverter defibrillator continues to be extremely important in many patients. And I also want to mention the subcutaneous defibrillator, and that's where you place the device on the side of the left side of the chest, and you tunnel the lead under the skin. So there is a lower risk of infection, so to speak. But the subcutaneous defibrillator is not capable of pacing, like the traditional defibrillator that I mentioned earlier. But it's definitely fully capable of monitoring the heart for any life-threatening rhythm and then responding with a shock if needed. Very important to keep in mind. And lastly, I would share with you that there is another form of defibrillator that is being studied right now. It is called extravascular defibrillator, where the thinking is that the device will be also under the skin. Here, the lead will be tunneled under the chest bones, so to speak, under the sternum. But this is still being investigated. Now, many people say, well, what about medication? Of course, medications can work. You know, beta blockers are essential in patients, you know, who have atrial fibrillation, who have ventricular arrhythmias. Very important to keep beta blockers in mind. Certainly a life-saving therapy in patients with heart failure. This has been shown time and again. And of course, we have different antiarrhythmic medications like amiodarone, like sotalol. Mexiletine is only used for ventricular arrhythmias, but just to kind of make you aware that there are these medications that are available, and in some patients, really a combination of having a defibrillator in place that treats the ventricular arrhythmia when it happens, and a medication that prevents the arrhythmia from happening is really the right way to go. So something to keep in mind. So I'd like to very quickly switch gear and talk about slow heart rates. So starting with what we call sinus bradycardia, meaning the slow heartbeat coming from the sinus node. And here you see the SA node, that is the normal pacemaker of the heart. And it really beats between 60 and 100 beats per minute in people who are normal, with normal hearts, what have you. Anything slower than 60 is, we call it bradycardia, meaning a slow heart rate. More than 100 is tachycardia, fast heart rate. Not everybody with a heart rate less than 60 needs a pacemaker, absolutely not. But people who have heart rates in the 40s, in the 30s, and are having symptoms as a result of that, meaning when the sinus node, and you'll see that EKG tracing on the bottom of the slide, showing you heart rate in the 30s, low 40s, that's basically what we're talking about here. This sinus node, instead of working at 60, 70 beats per minute, now it's at 30, 40 beats per minute. And if this causes patients to be fatigued, to be passing out, then a pacemaker is needed. And of course, there are issues affecting the AV node. I describe this structure to my patients as the structure that funnels electricity from the top part of the heart to the bottom part of the heart. So that may get blocked, so that electricity in the top cannot make it to the bottom, when you have complete heart block, so on and so forth. So we have these different pacemakers. The implantation of these traditional pacemakers is the same way as when we implant a defibrillator, basically putting a wire in the heart, connecting it to the pacemaker, showing you here a generator on the bottom with how we plug in this side of the leads into the header of the pacemaker. And very quickly, I want to share with you this most recent advance in pacemakers, where we now can go through the groin and directly embed this very tiny pacemaker into the right ventricle, the right bottom chamber. And this technology will continue to evolve, and it will hopefully become appropriate for a lot of patients, because patients with sinus node disease at this point cannot get this pacemaker, because this pacemaker is not capable of pacing patients in the top chamber. Switching gears and talking about heart failure. So in general, this is a major issue in the United States, affecting 400,000 to 500,000 Americans each year. Some patients with the Fabry disease will develop heart failure. So important to keep that in mind. Some important statistics here: as people age, of course, the risk of heart failure increases. And about 50% of patients with heart failure die suddenly. It's a big deal. And I mentioned heart failure with a preserved ejection fraction, but really one important type of heart failure is heart failure with a reduced ejection fraction. Really what the ejection fraction is, it is indeed a measure of how strong the squeeze of the heart is, how strong the heart muscle is. And so if the heart muscle itself cannot squeeze well, then people can develop heart failure. One point I wanted to bring up, if you look at data regarding heart transplant in patients with Fabry disease, in the literature, there are only case reports of that. So it really has not been done that frequently. But hopefully the future will bring more of that to patients who need this intervention. And I wanted to share this analysis of the Fabry Disease Registry with you, where they actually followed many patients with Fabry disease, looking at the natural history from a cardiac perspective, and found that 3.5% of men and 2.7% of women experienced heart failure, whereas 2.7% of men and 1.5% of women experienced a heart attack. And this cohort of patients first experienced their cardiac event at a mean age of 45 years in men, 54 years in women. So it was, more delayed, so to speak, in women. And of course, two risk factors most strongly associated with cardiac events in both sexes were a high blood pressure and a thick heart muscle. So I do want to mention, for people who have heart failure, obviously medications play an important role. I mentioned beta blockers. There are other medications that we use, like ACE inhibitors, Entresto, aldosterone antagonists like aldactone, spironolactone, and eplerenone, things like that. But, as an electrician, I always would like to think of device therapy also. And some patients, not all patients with heart failure, are candidates for what we call a biventricular pacemaker or defibrillator. And that's basically when we go through the vein and advance 3 wires into the heart. One goes into the right bottom chamber, one goes into the right top chamber, and one goes into a vein that wraps around the left bottom chamber. And this is basically to force those 2 bottom chambers to work together. And only patients whose EKGs show that those 2 bottom chambers are not working together are eligible for this type of device. But if the EKG shows that the bottom chambers are not working together, then this intervention by putting this biventricular device in can actually help patients feel better, give them energy, reduce their risk of heart failure, hospitalization, even reduce the risk of sudden cardiac death. And this is an X-ray of a patient who has this biventricular defibrillator device. A few words about implantable monitors, because there are a lot of patients out there with, or without Fabry disease who experience symptoms, but, it's still not clear whether they really need a pacemaker or a defibrillator. Maybe they're having palpitations. Maybe they're having symptoms like they're about to pass out or they are passing out. And so we start generally with external monitors that people can wear for a few weeks. But if that doesn't capture anything, or if the frequency of the episodes is such that you don't think that you're going to be able to capture something with an external monitor that a patient wears over a few weeks, then we implant a monitor. And I'm showing you here the first version of the monitor and showing you how it has really advanced in terms of a much smaller size right now. And basically, this is how we do it. We inject the a monitor under the skin. It sits in that location where you see in the left top image, and it monitors the heart. If it sees that the patient is having arrhythmias, we get notified remotely, actually. And a couple of words about consumer products. I show them here. There's the Alive Core in the right top image. There are some watches like the Apple Watch, things like that. Some really promising technology, but I personally don't feel that I can fully endorse and support patients using this technology without more data. We certainly need more data on the quality of the images, in terms of the tracings, as well as, the establishing workflows for when patients detect something. What is the best way to handle that as a clinical practice? Very briefly, the Apple Heart study actually was published in the New England Journal of Medicine, 2019, so just last year, where they took these participants, they wore the Apple Watch, and people who had some notification that there was an irregular pulse, they sent them a patch that they could wear just to kind of confirm that that these patients were indeed having abnormal rhythms. And the 450 participants who returned those ECG patches that were prescribed by the physicians who were part of the trial, they sent them in and they analyzed those data, and they found that AFib was present in 34% of these people. This is really just to make you aware that there is a lot of work that is being done in this space to show us data to validate the role of these wearables going forward. So hopefully you're not feeling like this from everything that I have shared with you. Obviously, this is a lot to share. But in enzyme replacement therapy, you heard from experts in this area. But as you heard, yes, enzyme replacement therapy can definitely help the heart. Several studies have shown that people who started using enzyme replacement therapy after having thickening of the heart muscle actually showed a regression of some of the heart muscle thickening, which is really great. One study of 39 patients treated with enzyme replacement therapy showed 8 major complications occurring in 5 patients, and 1 patient actually had atrial fibrillation. No sudden death, no stroke occurred in these people who were getting enzyme replacement therapy. And as I said, really showing in some people a regression or reduction in the left ventricular mass, which is really important to see. And I hope that this will continue to be investigated so that we can fully understand the effect of enzyme replacement therapy on the heart. And before I conclude, I just wanted to show this slide relating to the cardiac complications of COVID-19. Obviously, we are living in this new reality now, and they're listed here. Myocarditis is basically inflammation of the heart. And when you have inflammation, that can always have the potential to lead to scar formation. And that's when we start seeing arrhythmias, as I mentioned to you earlier. Heart attacks, heart failure, pulmonary embolism, deep vein thrombosis. Arrhythmias, mostly we're seeing atrial arrhythmias, atrial fibrillation. However, especially in the setting of myocarditis and heart failure resulting from that, we are seeing some ventricular arrhythmias as well. So to conclude, Fabry disease can affect the heart, as all of you know. Most common sign is thickening of the heart muscle. But we actually have data that enzyme replacement therapy can help that. And it can certainly cause arrhythmias, as we explained, and heart failure. Not all patients will develop these complications, so important to keep that in mind. And as I mentioned when introduced, early enzyme replacement therapy appears to have positive effects on the cardiac manifestations of Fabry disease, but we certainly need more data. So with this, I'll stop, and thank you so much for your attention.
Wonderful. Thank you, Dr. Al-Khatib. We'll do some claps. We have some good questions for you too. But first, I want to tell you that the secret word that you need to put in the messenger to be in the drawing is heart. So your name and heart in the message, so that we can get some individuals a great, fabulous prize soon. All right, Dr. Al-Khatib, let's see what we have for questions here. I think let's start with this one. If you have a hypertrophic cardiomyopathy or dilated cardiomyopathy genetic marker and Fabry, do you know if there's any additional information about progression and how that might impact the heart?
So the question is hypertrophic cardiomyopathy, not like this thickening of the heart muscle, not in relation to Fabry. But the question is that this person has both Fabry disease and HCM.
I think they may not even have HCM yet, but they had genetic testing which showed they had a predisposition.
Yeah, no, I'm not aware that there are data in that area. Happy to look for it, but I'm not aware of any data.
Okay, thank you. Here's one. Are teens that are on enzyme replacement therapy or Galafold less likely to have cardiac complications in the future?
Yes. Yeah, absolutely. The data are definitely compelling, because as we talked about, if you look at the thickening of the heart muscle, we said that if people indeed take enzyme replacement therapy, that shows regression of the thickening of the heart muscle. And a lot of the complications that I mentioned are indeed mediated by the thickening of the heart muscle. So the less the thickness, the better. What is not clearly known yet, though, is if enzyme replacement therapy directly affects scar formation. And indeed, if it does, if we show that some of these therapies do reduce scar tissue, then yes, I would expect that we would see a reduction in arrhythmias.
Mm-hmm. Excellent. Here's a question. What's the significance of ejection fraction if you've already had an MRI with scarring shown? So I guess, how do they correlate?
Yeah, so there is some correlation. If people have a lot of scar tissue, I do expect the ejection fraction to be lower than normal. And just so people know, the ejection fraction is this measure of how strong the heart muscle is. And anything more than 55% is normal. Because like when I talk to people, oh, your ejection fraction is 55%, I see like their face, they get sad. I'm like, no, actually anything more than 55% is normal. We're not comparing your ejection fraction to 100%. It's more than 55%. But there are people out there who actually, whose ejection fraction is like only slightly diminished, maybe 50%, but have significant scar tissue. And both have prognostic value, by the way, in general. When it comes to like sudden cardiac death risk stratification, the lower the ejection fraction, the higher the likelihood of these ventricular arrhythmias that could cause sudden cardiac death. And the more the scar tissue, the higher the likelihood of arrhythmias as well.
Yeah, I think along that same line, if you've got a preserved ejection fraction, particularly like you do in Fabry, why is that? Why does it stay at 55 even though people have a lot of heart damage?
Yeah, so that's, as we mentioned, really, if you look at the literature, the most common cause of a reduction in the ejection fraction is when people have a heart attack, a significant heart attack, either massive or large heart attack. And so they lose a good part of their heart, so to speak. However, in Fabry, the other condition, by the way, that I should mention is dilated cardiomyopathy, or non-ischemic cardiomyopathy. And that's also usually in the setting of like viral infection of the heart, causing viral myocarditis. And that can indeed weaken the heart muscle per se. In Fabry disease, there's really nothing that is causing the heart muscle itself to get weaker unless the person has a heart attack. But as you saw, the incidence of that is not that high. So there's nothing causing that, but definitely you have those abnormal deposits leading to thickening of the heart muscle. And so we're more likely to see heart failure with preserved ejection fraction in those patients.
This is slightly more personal question, but still important. If you knew that a patient had an ICD-9 that flipped and seems a little bit more unstable, keeping flipping, would that be a concern to you? And would you consider replacing that?
I'm sorry, you broke up a little bit.
Sorry. Would you be concerned if a patient with Fabry had an ICD and it flipped over 180 degrees?
Oh, wow, okay. This is not specific to Fabry. This could happen at times. If the leads are still in place and the function of the device is good, then no, we don't replace. Because remember, every time you go into the pocket, the risk of infection goes up. So we do our best to avoid going into the pocket. So if the device flipped 180 degrees, the first thing I would do is do a chest x-ray to look at the leads, make sure that they're fine. Second, we definitely need to check the device, the lead, make sure that everything is fine. But pertinent to that, where we see that more often is people who are like overweight, and in women especially, where the device may migrate, so to speak, not necessarily just flipping. And so I have the habit of cinching the device, because there is a hole in the header of the device where you can actually put a stitch in. So you stitch it to the underlying muscle you keep it from migrating, you keep it from flipping.
Ooh, good answer. We have another question. I am suffering from recurrent persistent AFib. Cardiologists who are not connected with Fabry always tell me to get an ablation. Those are connected to Fabry say it won't do any good. Do you have an opinion on that?
Yeah, I do. Absolutely. Gosh, how much time do you have? So it all depends on the state of your heart. And I say this is, do you have a lot of thickening of the heart muscle? What is your left atrium? The left atrium is the left top chamber. What is your left atrial size? Because here's what I would say. If the heart muscle is very thick, and that left atrium, left top chamber is really significantly enlarged, then the odds of having a successful ablation procedure go down significantly. However, if you don't have a lot of thickening of the heart muscle and the left atrium is not, significantly enlarged, then it is a good idea to consider an ablation procedure. Certainly make sure that you go to someone who is experienced with the procedure, know your other options. I'm not sure if you've tried anti-arrhythmic medications, so on and so forth.
Oh, right. Well, we're talking about anti-arrhythmic medications. I know there's some medications that we've been told in Fabry to stay away of, such as amiodarone, because it can interfere with the lysosomal function. Do you want to comment on why that might be and why how a doctor might think about that?
Yeah, there is definitely a thinking out there that amiodarone may not be the best medication to use in patients with Fabry disease. So we have avoided that. Do we have enough experience to know what the effects are? What is the severity of the effects? No, we actually do not know that. But I personally do avoid using amiodarone in patients with Fabry disease.
Thank you. Let's see. If one has a resting heart rate of 44 and a Holter monitor shows that with exercise, the heart rate increases to the 60s or low 70s, is there a value to a pacemaker?
Oh yeah, it all depends on how symptomatic that person is. That's a good point in terms of the Holter showing the rate goes up to the 60s. But what I also want to know is like when this person is more active. And what I mean by that is even like brisk walking, what does the heart rate do? You know, like not long ago, I actually had a patient in my clinic with Fabry disease whose heart rate was slow. And I just walked that patient in the clinic to see what the heart rate does. And the heart rate did not go above 50. So we call that chronotropic incompetence, meaning that the sinus node, the normal pacemaker of the heart, is not able to increase the rate based on the body's need for a faster rate. And so the biggest question for that person, are they having symptoms? And if when the Holter showed the heart rate was up to 60, 70, how active were they? If they are indeed like fast walking and the heart rate is not budging above 60, they may have chronotropic incompetence and a pacemaker may be helpful.
Thank you. Do you see many implantable ICDs with 3 leads used in treatment, particularly for pacing the heart?
Yeah, well, in general, yes, definitely. We use that quite a bit. You know, again, Fabry disease, there aren't too many patients with Fabry disease out there. I personally have probably 5 in my practice. Yes, we have definitely used the biventricular device in patients in general. And, you know, again, not a lot of experience in patients with Fabry disease, but if you select the right patients for this device, you can expect that 70% of these patients will have significant improvement in the way they feel, more energy, better breathing, less fatigue, less heart failure, hospitalization, so on and so forth. But it really goes back to, you know, how you select the patients. Not everybody would benefit the same.
All right, excellent. I think that's the, there might be one more question here. Yep, okay. Yeah, there was just a comment from someone that said they have 3 leads currently. It's been a year and it's worked wonderfully.
Yeah, that's exactly right. Absolutely. One comment I'd like to add, if I may, since we do have a few minutes, is if going back to the person who may need a pacemaker, I think it is important, like if you are deemed to be a candidate for a pacemaker, to also be risk stratified for, you know, ventricular arrhythmias. Like so if you've never had a cardiac MRI, perhaps get a cardiac MRI to assess the scar burden. And many people ask, well, what is that? How much scar burden do I have to have, you know, to put me in a higher risk category? And we certainly don't know the answer for patients with Fabry disease. But what we do know in HCM, somebody raised that question earlier, it seems like 5% scar burden is that threshold for patients with HCM, by the way, that if they have 5% or more, that puts them in a higher risk category of having life-threatening arrhythmias and potentially having sudden cardiac arrest. So we've been using that 5% with other patient groups just because we don't know. We don't fully understand what the threshold should be in patients with Fabry disease, but I do feel that if a person is about to get a pacemaker, it is important to get their clinician to risk stratify them for ventricular arrhythmias.
Is it particularly unusual to ask for 3 leads? So if someone was in that category and they were doing their risk stratification and they said, can I have 3 leads? Would that be unusual?
I mean, the patient definitely can ask for anything. The physician, though, should look at the EKG very carefully and decide whether, based on the EKG, and really what we're looking at it is to see, do they have left bundle branch block, or is it right bundle branch block? Because the data are much more compelling for left bundle branch block. Usually my approach with patients with right bundle branch block is I do a special type of echocardiogram, that's the ultrasound of the heart, to look for evidence of dyssynchrony, we call it, meaning that the heart is not working together. So I look for echo evidence of dyssynchrony in patients with right bundle branch block, but it's really patients with left bundle who benefit more. If they don't have exactly left bundle, but their QRS duration That's the other thing that we look at is really wide. Those are people who could potentially benefit from a third wire.
Great, thank you. And I think one final question, is there value in Fabry's patients to have a coronary calcium scan?
You know, we certainly use it in patients who have risk factors for coronary artery disease in general. So I would say the same thing would apply to a patient with Fabry disease in terms of if you have risk factors like high cholesterol, diabetes, hypertension, even potentially having some, you know, atypical chest pain or something like that, then it certainly would apply in terms of the value of getting that type of CT.
Okay, thank you. All right, thank you so much for this wonderful talk. I think it's so valuable for us to hear your insights in the heart and how Fabry is affected by it and best practices. So thank you so much.
Thank you so much for having me.